Hello, everyone. Welcome to my channel. I am Dr. Zina, a full-time dentist. Today, we will be talking about the steps of direct pulp capping. But before we continue, make sure to subscribe down below in order to receive any updates that I upload. Direct pulp capping is a technique that is used in dental restorations to prevent the dental pulp from necrosis after being exposed or nearly exposed during cavity preparation. As the name suggests, direct pulp capping. So there is a direct exposure of the pulp, meaning that we need to do pulp protection against it. So the treatment will be direct pulp capping. The indications for direct pulp capping are as the following. For permanent teeth needing a simple restoration, not primary teeth, recent trauma less than 24 hours, minimal or no bleeding at exposure site, normal sensibility test, meaning that normal cold test, the tooth is not tender to percussion, no any periradicular pathology, and for young patients, not elderly. The contraindications for direct pulp capping are if the patient is having a certain systemic disease that interferes, or for primary teeth. Why? Because the primary teeth are highly vascular, and if you did direct pulp capping on primary teeth, then it will result in resorption, and that's not a good thing, as well as if there is any sign of inflammation or preoperative tooth sensitivity, or if we have a large pulp exposure because it is indicated for a pinpoint exposure of the pulp that is 1 millimeter in diameter, or if we have uncontrollable bleeding, meaning that the tooth is not indicated for direct pulp capping, or if it is non-restorable tooth, and for elderly patients, 70 years and above. So a patient came, 24-year-old, and we did a cavity preparation for him, class 2 cavity preparation. And by mistake, we did a pulp exposure. It's not by mistake because just the caries are very deep. So we removed the caries. And then there was a slight pinpoint exposure of the pulp. So here we decided the treatment will be direct pulp capping since there is a pinpoint exposure of the pulp. So we placed an MTA and dentine liner to protect the pulp, followed by etching with a 37% phosphoric acid and bonding agent before applying composite. We started building the distal wall with a composite. Very important if you have a class 2 composite whether mesial or distal, you need to build the walls first before starting occlusally. Now for the occlusal surface, you can build it with a composite or with a temporary filling. Then recall the patient after 1 month exactly, not less, not more, to see if there is pain or no. Now, if the patient calls you after 1 week of the direct pulp capping procedure, he tells you, I have a very severe pain, then it is also indicated for root canal treatment. We cannot keep the patient for 1 month. Okay, we cannot keep the patient for 1 month suffering from such pain, meaning that it is immediately contraindicated for direct pulp capping. We need to do root canal treatment to remove the pulp and let the patient relax. If there is no pain, then you can place the permanent restoration and ideally is composite. On the occlusal surface, build the composite by layers, which is incremental placement of the composite because composite is a weak material. So you need to build it in layers to make it very strong so that when the patient bites, he won't break the composite. Once you are done with building the occlusal surface, remove the rubber dam, check the occlusion by articulating paper, ask the patient to open and close several times, then do finishing and polishing. It's a very good idea to do polishing even if there is no high point because to remove the rough surfaces, any rough surface that is present on the tooth so that the patient, he won't feel any different thing when he bites. Thank you all for watching my video. If you enjoyed, don't forget to press the like button, comment down below if you have any questions, and subscribe for more videos. Goodbye.